Good morning, everyone. I'm Shara Holzberg, Chief Care Services Officer at ALS United, Greater New York, and it's my pleasure to welcome you here to day 2 of our 6th Annual Education and Resource Summit. At ALS United, Greater New York, many of our staff and board members have a deeply personal connection to ALS. All of us are passionate about advancing care, supporting families, and working towards a cure. And much of our work is made possible because of this community. Whether you're living with ALS, caring for someone you love, newly navigating this diagnosis, or have been part of this community for years, we thank you for choosing to spend your time with us this week and for engaging in these conversations. We're proud to stand beside you and remain dedicated to ensuring that your voices are heard. Some of you joined us yesterday for the incredible sessions with Her ALS Story. I want to once again extend a heartfelt thank you to the ladies of Her ALS Story for their openness, vulnerability, generosity, and humor in bringing important conversations to the forefront. Over the next 2 days, you'll have the opportunity to participate in a wide range of sessions and discussions covering many aspects of the ALS journey. We hope these sessions leave you feeling informed, supported, and perhaps even thinking about ALS in a new way. And with that, it is my pleasure to introduce Bob and Chris, who will be moderating our first session for the day. Enjoy.
Thank you, Joya, and welcome everybody to session 1, Why, When, and How Feeding Tubes and Nutrition for ALS Patients. I'm Bob Twasutyn from the Long Island region, a registered nurse, and this is Chris Dunn, my co-moderator for today. And we have the privilege to welcome Susan Kraus. She's a MSRD, registered dietitian. She's been practicing 47 years. She's has a diverse background working in multiple environments, as well as has been part of our medical center over at Hackensack University Medical Center, ALS Clinic.
Good morning, everyone. I'd like to introduce Theresa Imperato, clinical nurse specialist. Theresa has been with ALS United, Greater New York, for nearly 30 years, serving ALS centers on Long Island and New York. She has been helping patients decide on whether or not to get a feeding tube for as long as she has been working at the certified ALS centers. Theresa provides support before, during, and after their feeding tube decision has been made. Thank you.
Speakers, the floor is yours.
So I'm Theresa Imperato. I'm a nurse with ALS United, and I've worked at several different clinics. And one of our focuses is generally feeding tubes for those patients who are losing weight or becoming dehydrated due to complications of their ALS. Susan will present to you all the nutrition recommendations for maintaining your weight and your hydration, and for maybe pushing off that feeding tube. And I was going to take over on when and where and why to get a feeding tube. Okay, so what is a feeding tube? So a feeding tube, for those of you who've never seen one before, is a small flexible tube, which is about a quarter of an inch in diameter. And it just serves as an alternative route to your stomach that will provide you hydration, nutrition, and medications. There are basically two types of tubes, and we call them pegs or rigs based on where they are placed at the hospital itself, what room you go to. So a PEG stands for percutaneous endoscopic gastrostomy tube. Percutaneous simply means it's going through the skin. Endoscopic is how it's done with a little camera and with a flexible camera that goes into your mouth and down into your stomach so the doctor can see where they're going to place the tube. And the gastrostomy is just the word for a hole in your stomach. A rig is a radiographic inserted percutaneous tube, and that just means that it's done in the radiology department, and they don't use the endoscopy tube. They use the radiology equipment so that they can see the tube, see where they're placing the tube radiographically. So here is just what a tube looks like. The original tube that they put in your body is going to be externally like 6 to 8 inches long. and it will have an opening at the end. I'm hoping you can see this, an opening at the end where you can place a syringe to put food. That's what we call a standard tube, and many people will keep this tube and will have the same tube. It gets replaced every year to 2 years, as if it's working fine, you don't have to worry about it. Some people want to move over to a low profile tube, and once your site is healed, which usually takes 8 to 12 weeks, a doctor, you can go back to the wherever you got the tube done in the GI suite or percutaneous, or the interventional radiology suite, and they can put in a smaller tube. If you see here, this tube is, just a couple of inches long, and it goes in your stomach, and then just this little bit is hanging outside, and it looks like a button on your belly. And that tube, for many, we call it a low profile tube, and for many people, that's better for their image. They don't see anything under their stomach, and they choose to use this. This tube, though, has to be changed every 6 months to make sure that it's stays good quality and that it works properly. That tube can get changed at the clinic when you go to your ALS center. The nurse or the nurse practitioner can change that tube for you. So who should consider getting a feeding tube? Sue will explain a little bit more what we're monitoring, but we check your weight every time you come to clinic, and we want to make sure that you don't go past your 10% weight loss. So we monitor some people want to lose a little bit of weight. We advise against that. We want our patients to maintain weight, because when you lose weight, you lose muscle. So we want to make sure that we keep as much muscle as possible on your body. So we do not recommend weight loss. We want to make sure that you're not dehydrated. So we're going to monitor you for dehydration. The doctor, the nurse, the nutritionist, they will look at your skin for patches of dry skin. They'll ask about constipation, if you have bleeding gums when you're brushing your teeth, cracked lips. These are just some of the basic things that we look for feeding tube, for dehydration. And when your fluid intake is below normal, and most patients will be able to say, oh yeah, they'll all say, oh, I drink plenty of water. And then when you say, how much do you have? They say, oh, I have 8 ounces a day. 8 ounces of water is not enough water to be taking in a day. And Susan will go through that. But if you can readily admit that you are not getting enough fluid, there's a good chance you need that feeding tube done. We also monitor your breathing. And so we're going to look at your pulmonary function every time you come in, and we will recommend a feeding tube if your numbers drop. We don't want them to be too low. But if you notice that you're short of breath and just mild activity, or when you're eating, if you have to pause to catch your breath while you're eating, those are indications that you are not getting enough, you're not breathing well enough to eat well enough. And then if you had a history of pneumonia over the last 6 months, or you have recurrent pneumonia or lots of congestion, there's a good chance you're aspirating on the food that you're eating or the liquids that you're drinking, and that aspiration, that stuff is falling into your lungs and causing you to get a pneumonia. If you've had multiple pneumonias over the last couple of months, that's a really good time to consider getting the feeding tube. And then many people will have decreased energy, because calories give you energy. And if you do not have enough calories to provide that energy, you're going to be napping. You're going to have no energy to do things. And we want you to be able to do as much as possible for as long as possible. So let's get those calories in whatever way we can. And then here in the US, most of us eat our breakfast, lunch, and dinner in under 20 minutes. If you're sitting there chatting with people, it may extend it to 30 minutes. But really, to sit and eat a meal should not take you that long. So if your meal time on a regular basis is greater than 30 minutes, then you are having lower caloric intake, or you're exhausting yourself just to get the calories in. And that's a good time to get the tube to help you supplement your calories. So why do we recommend the tube, and why would somebody get the tube? Because we want you to maintain your hydration, It's just an extra place for you to throw that water down. We want you to get your medications in safely. Many people I know have trouble swallowing pills since they were a child, and now we're giving them more medications to take. We want to make sure you get them in and that you're not choking on it. So this is a good way to get the medication in. Most medications can be crushed, mixed with water, and just sent down the tube. It reduces your risk of aspiration. It reduces your risk of choking. If you have chewing and swallowing problems, it's a good idea to get that tube. We want you to help maintain your weight, reduce your fatigue, and increase your your resistance to infection, because proper nutrition helps you fight infection. Proper hydration helps you fight infection. So the tube is a win-win. It will reduce your meal time so you can continue to eat, which you can safely eat, and then you can just supplement your calories with the formula that we prescribe. And it makes sure that it's giving you a stable, nutritious diet. When we want to get it in, before you lose that 10% weight loss. So if we have a man that comes into our clinic who has started his adult life, he's been walking around on or about 200 pounds, and he's now at 180, he's lost 10% of his weight. 200, 10% of that is 20 pounds. So if he's at 180 or less, he's at the point that needs a feeding tube. We're definitely going to be pushing for it. If we're measuring somebody and their pulmonary function tests, the results are 50% or getting close to 50, under 60%, we're pushing for that feeding tube. If you've had pneumonia over the last couple of months, again, we're pushing for the feeding tube. Here's another one. People will say, all my life, I've been very active and I've never had any constipation. Now I notice I'm constipated. That's an indication of dehydration, and the amount of effort it takes to have a bowel movement, you're burning calories just to have the bowel movement. You need to have that tube. People who are telling me they're falling asleep in the middle of the day or they're going to bed earlier, chances are they're not having enough calories. And if we're checking for malnutrition, whether it's through blood work or just a physical assessment of the patient, we want to make sure that we get that tube in. So the other thing that's very important in getting the tube is if the family is resistant or the patient is resistant, it's not going to work. So we need to have the family and the caregivers aligned with the patient to get the tube. When everyone's ready, then we set up that tube appointment. And when the procedure itself outweighs the risk of the procedure, so the need of the feeding tube and the benefits of the feeding tube override the risk of the feeding tube. If it's still okay, then we'll get that feeding tube in. And then we want to make sure that our medical team at our clinic and the medical team where that's getting the tube in understands your disease process. We can get the information to them. They can get information to us and make sure that the placement is safe. So where would you go to get the feeding tube? Well, first place you would think of is the ALS center or the ALS clinic that you're currently attending. You go to that clinic, that doctor, that nurse practitioner, that nurse, that coordinator will set up the appointment. They know what those doctors and wherever you're going to get it done, what they want, whether it's blood work or breathing test results or a CAT scan. Those things will all get done for ordered for you so that you can have everything done before you have the procedure. Many places are using interventional radiology to put in a rig, and it's an outpatient procedure. Interventional radiology uses less anesthesia. They may give you a little bit of anesthesia in your IV to calm you down, to keep you relaxed and make you be able to, if the doctor says, turn your head or take a deep breath, you'll be able to respond to that order. And then they'll give you, like they do at the dentist when they're doing a filling or taking a tooth out, locally, right where the tube is going in, they'll give you some anesthesia. The reason interventional radiology is the choice of many places is because the recovery time is quick, and usually you can go home a couple of hours after the procedure. But some places use the GI suite or the operating room, and that's fine too. All these GI suites and operating rooms have been putting in feeding tubes for a long time. They're going to be putting in a PEG tube, and the only reason you would go for the interventional over the GI suite or the OR is because they use less anesthesia in interventional. It's just a little bit higher risk for those people who have respiratory complications. And some hospitals will require that the patient stay overnight, either before to get hydrated or after for recovery because of that a little bit higher amount of anesthesia. And then usually the first feeding will be done in the hospital before discharge. So for the most part, though, even if you do go to OR or GI, it usually is an outpatient procedure. So it's what we call same-day surgery. You go in the morning and you get all prepped that day. They'll start an IV line. They'll go over your medical history, blah, blah, blah. And then you have the procedure done. You'll go into the recovery area for as short a period of time as possible. Most people are discharged in about 2 to 3 hours from the recovery area. And then you get sent home with a little education packet to take home with you that day for the overnight. And then the following day, your ALS clinic team will have set up visiting nurse to come in and teach you how to take care of the tube, how to clean the wound, how to flush the tube, how to administer medication and formula. Some doctors want to make sure that they keep the patient in overnight just to make sure if there's a little extra pain or any sort of complications, they can be right there. But this is a low risk procedure. So why are we getting the feeding tube? I'm going to just keep reiterating. And when you hear Susan, she'll be telling us the same thing. We want to get medications in safely, on time, and at no risk. We want to make sure you're getting your medication. We want to make sure you're getting all the calories you need for the day. So it's a perfect option for nutrition. And we want to make sure you're hydrated. Hydration, very important. Keeps the muscles moving, keeps the joints moving, keeps your bowels moving. Okay, so there's a couple of different ways that we could administer the feeding tube. And the most basic and the most common is a bolus feeding. A bolus feeding is just through a big syringe. I hope you can see this. This is a big syringe. It's 60 cc's or 2 ounces. There we go. I think you can see it. It has a big opening at the top like a funnel, and it has a big bottom. The bottom, the syringe itself will go into the tube. And there's a couple of different types of tubes and syringes, but basically it's the same idea. You stick it inside the tube, and then you simply just pour your water. I don't know if you can see this. Pour your water, then your formula, and then water again. And that procedure usually takes between 5 and 10 minutes based on the patient's tolerance. Very simple. When it's all done, you take the syringe out, you close up the cap, and then you wash the syringe. You can use it again later. Some people, though, may have waited too long for their feeding to be placed, or they simply have a problem tolerating that high level of calories going in at once. I like to think about it as if you were to go to McDonald's and buy a milkshake and then drink the whole thing really fast, you're going to end up bloated, maybe some gas, maybe some nausea, maybe some diarrhea. So I advise not to go to McDonald's and drink that big shake, but I also tell patients that are maybe having some intolerance to the formula we're giving to spread it out slowly over time. So those patients, we recommend a gravity bag. So this is a gravity bag. It's about an ounce, a liter, and you would pour the 1 container of formula, which is usually 8 ounces and or 350 cc's. You pour it in the gravity bag, you close it up, and then you let it hang for, a half an hour, 45 minutes. And it has a little spigot to make it go faster or slower. You open and close this, and the higher you hang it, the faster it goes. You can just put a command hook on the wall right behind where you normally sit, and you can hang that bag right there and let it run in slowly over an hour, 2 hours, and you get your calories that way. And you tolerate it well. You can use that bag for 24 hours. So rinse it out every time you finish using it. You disconnect it, you rinse it out, come back later. But then some people still can't handle. People maybe had some dietary problems before where they didn't tolerate, different kinds of foods, and now we're giving them, something that their body is going to have to get used to. Those patients will put on a pump. The pump is just like you see in the hospital, like an IV pump. It'll be on a pole, delivered to your house with a pole. You plug it in, the nurse from the visiting nurse will come and show you how to set it up. It'll be set up once and done, and it will have two bags usually. One bag for formula, one bag for a water flush. And that would get set up, programmed by the nurse, and we can have that run over 24 hours. We could have it run over 18 hours, 12 hours, whatever way the patient tolerates it the most. Many patients will eventually get to speed it up from, let's say, a half an ounce an hour, then 2 to 3 ounces an hour. And then once they speed it up to that, then sometimes we can go to that gravity bag and then eventually to bolus feedings. So, many patients will end up getting rid of that pump, but not everybody. And whatever your preference. The pump just leaves you a little more tethered, but the other stuff you can take and move wherever you want. So, when do you start using the tube? Generally, we give it a 24-hour rest period after the procedure is done, but the doctor who does the procedure will dictate 24 hours, 18 hours, whatever it might be. The nurse will come from the home care agency. She will show you how to clean the wound, change the dressing, and how to use the tube. And she or he will use the administer the fluids for the first time and some formula for the first time. The dietitian is going to set up a schedule for you. Many times we start the patient like 1 container the first day, 2 containers the second day, 3 containers the third day. If you're tolerating it, then you'll go into whatever the dietitian has recommended. Some are 4 cans a day, containers a day, 5 containers a day, maybe 6 containers. It's all based on your weight at the time that you got the tube and what we want you to get to. And then, of course, once you're ready as a patient, once you're ready to start using the tube, you'll start using it. Some people get the tube early and they don't need to put any formula down the tube. So we're just going to put water down every day, once a day, just to make sure that it's working and we don't have any complications. And of course, we want everybody who's going to be involved with the tube trained. So that's family members, caregivers, neighbors, and the patient themselves. So where do you use the tube? As long as your hands are clean, you wash your hands, whether with a hand sanitizer or go to the sink and wash your hands with nice warm soapy water, you can use that tube anywhere. You can do it on a plane. You can do it in the car. You can do it in your living room, in your bedroom, in your kitchen. You can do it at the movie theater, wherever you want. It's just like filling a bottle of baby formula and giving the baby anywhere, taking the baby anywhere and feeding them. This is the same thing. You'll have containers of food. You can take it with you and you can administer it anytime, anywhere, whenever you're hungry. So just to reiterate, it's patients who have swallowing problems, trouble taking medications, can't maintain their weight no matter what. I mean, I have people tell me, I'm eating 4 meals a day and snacking, and I'm still losing weight. Those are the people. You can keep eating those 4 meals a day, but we're just going to give you some nice, high nutrition, high caloric formula to help you maintain the calories that you need. And those patients who want to really fight the disease, because in my humble opinion, I feel feeding tubes are the best way to fight the disease. You're hydrated, you have all the calories you need, all the nutrition you need, and you're getting your medications. It's a great way to fight the progression of the disease. When this slide will come back later after Susan. I'm happy to answer questions later. Thank you, everybody.
Theresa, we have just one question from the audience about how much water should they be using with the feeding tube for flushing and
well, we can go later. Susan's going to go over hydration and stuff like that in her slides, so we can answer those questions later if you don't mind.
Very good.
Thank you.
Okay. Hi, everybody. Thank you, Theresa. That was great. And some of the things there might be some repeat things I'm going to talk about, but it's probably good for people to hear it. Again, hopefully everybody sees the slides. Do you see the slides now? Hopefully,
all good, Sue.
Yes, all good. Okay,
yes.
Thank you. That's one thing we don't learn in school is how to technology, but I'll get better. Anyway, so I know it's very overwhelming, when someone's diagnosed with ALS or any other kind of neuro cognitive or degenerative condition, and there's so many things to think about. Tube feedings a lot of times is pushed to the back burner, especially if people feel that, oh well, I'm still eating. But it's something, as Theresa mentioned, is very important. We know that ALS is considered a multi-system disorder. You know, there's a lot of metabolic imbalances. We find this increase in even our resting energy expenditure, and there's a lot of energy costs just to even breathe. Some people feel that what they call mitochondria, or the powerhouse in our cells that helps produce the cell's energy, there's some dysfunction there, as well as also the increase in the nervous system activity, and also the vesiculations, the muscle twitching. All these generate a lot of need for energy. So on average, most people will need about, I would say, at least 35 calories per kilogram. Now, a kilogram is 2.2 pounds. Sometimes I do other calculations, taking into account someone's age, height, weight, and we even add more. But as we talked about before, Theresa mentioned, even if someone's weight is higher than preferred, the goal is for weight maintenance, okay? And certainly once someone loses weight, we want to promote regain as much as possible. So just as an example there, someone who is about 154 pounds or 70 kilos will need at least 2,100, and that's probably on the low end, but probably closer to 2,500 calories to maintain that weight. So protein is also very, very important for a lot of different reasons. We want to prevent malnutrition related to those muscle losses that are happening, to manage that hypermetabolic state, to keep our immune system healthy. And certainly, typically, adults that don't have medical issues need about 1 gram per kilo of body weight, okay? And even as we get older, sometimes that does go up because of what we call sarcopenia, or muscle loss. But with ALS, you could see it's increased to 1.2 to 1.5 grams per kilo. So again, that same 70 kilo person needs up to or over 100 grams a day. So what does that look like? And I wanted just to show this to you, because people say, well, I could get that from food. But take a look to see, can a person consistently have 9 ounces of protein, which again, a deck of cards is a 3-ounce portion, so 3 decks of cards, 2 portions of some kind of dairy, 9 servings of kind of starch or grain. A serving would be a scoop of potatoes or rice or a slice of bread. Vegetables, 4 servings of fruit, and 9 servings of fat. Now, that sounds like a lot of fat, but a teaspoon of oil is 1 serving, just to give you an idea. But you could see it's a lot of food. It's a lot of food to consistently feel, can I manage that? Especially when people are having difficulty breathing, and of course the issues with swallowing, extra saliva, all these play a role in preventing that from happening. Now, as mentioned before, Theresa mentioned fluid requirements is very, very important, because dehydration can occur very quickly with increased issues with difficulty swallowing, needing to thin out that thick phlegm, and also, with the weather getting warmer and even having heat in the house, both of those things can increase our fluid needs. Now, like I said before, thinning secretions is very important, so fluids will help with that. And also, as Theresa mentioned, constipation, which becomes an issue. So we need the fluid, because it's one thing for us to say, okay, we're going to give you fiber, or we're going to have you take Metamucil. But if you do not have the fluid to accompany it, it's not going to solve your problem. Then you're going to have even a bigger problem. So fluid requirements for most people is 30 milliliters per kilo of body weight, or half of someone's weight in their pounds would be what they would need in ounces. So for instance, that same person would need about 70 ounces of fluid a day. Okay. So again, it's the consistency that we're looking for. Now, certainly we do want to consider fiber, because why is constipation happening? Especially when people will say to me, I've never had an issue. But again, there's less mobility. There's decreased overall intake of food and fluid. And again, a lot of people find high fiber foods can tend to be harder to chew and swallow. And a lot of people will have a need for things that are softer and easier to chew, which can be lower in fiber. Okay. And also affects, what are some of the other causes of constipation? The side effects of medication, the muscle weakness, especially in the abdominal or pelvic area. Our autonomic nervous system there's a dysfunction there. So that also slows down gastric emptying and digestion. So it's a combination of a lot of things that are going on. So someone's need is 25 to 30 grams per day. Now, there are fiber sheets I give to my patients when I see them. However, what I usually will say to someone, if you get a hold of if you're still taking food by mouth and you're saying, oh, I got to up my fiber, what I usually tell people to do is take a look at a chart, kind of give yourself, to get an estimate of how much you're currently taking in, and not jump up to 25 to 30 grams, but rather increase it by 3 grams from what you're taking for a few days. Then if you tolerate that, increase it by another 3 grams, because it's very overwhelming to take too much at one time. Okay. The other thing, of course, we always have to consider are other medical issues that people have, because, when we're addressing, nutrition or addressing what they're doing, we have to see what other issues, food hypersensitivity, if someone has GI issues, if someone has diabetes, all these play a role. We just had a gentleman at our clinic that we believe probably has what they call gastroparesis because of long-term diabetes. So that also plays a role in what is going on as far as what is that person being able to take. Now, swallowing issues or dysphagia needs to be addressed early. And a lot of times at most clinics, we do have a speech pathologist that will do a chair-side quick swallowing eval and to determine maybe the proper consistency of food, and also based on what we discuss with the patient, what is going on, what can you tolerate. And a lot of times there's a consideration for, if someone's saying observed by the patient and the family, then, and the speech therapist might recommend a modified barium swallow or some other kind of swallowing eval. Okay. But again, even if that's not done, if someone has experienced all these issues, and again, as Terry mentioned, when 10% of weight loss occurs, that's the red flag to say we need to do something. Now, a lot of times, and again, everyone has to be in agreement, family and, of course, the person going through it. We will not force it on someone, but we will give the explanation of why this needs to be considered. So a lot of people will make a decision maybe to have a feeding tube placed while ongoing treatment and monitoring, because a lot of people sometimes feel, wow, I'm getting a tube. Does that mean I can't eat anymore, even if I'm able to? Absolutely not. We want you to still enjoy what you're taking by mouth, but it actually will take the pressure off if knowing that you can get your additional fluids from the feeding tube and maybe supplemented with some other additional calories and nutrition. Okay, so as was mentioned before, it's essential for the timing of the placement to be performed, again, when the respiratory status is still stable, before what we call the FVC, the forced vital capacity, falls below 50% of predicted. Now, typically, what we look for predicted is 80 to 100, 120%. So 50% is pretty relevant already, okay? But we know that when placement is done earlier, that can ensure lower risk of surgical complications, especially when placing the tube, especially if someone has respiratory issues, as Theresa brought up. Now, like I said before, it's to supplement initially, and as it becomes more difficult for someone to get in enough calories and swallowing, then the transition could be a little bit smoother than considering it. Okay, now it was mentioned before, so I'll just quickly scan over this. There's different type of tube types, just as Theresa said. The nasogastric tube, that is a temporary measure because someone's not going to have a long-term tube coming, through their nose, okay? But there's the gastrostomy tube, or the PEG, that's surgically placed into the stomach. Then there's the J tube, and that's placed into the small intestine, or the jejunum. And there's also a gastrojejunostomy tube, and that's surgically placed into the stomach, but goes right into the jejunum. Now I just have some pictures here just showing that you could see the gastrostomy tube is at the upper part of the stomach. You can see there. The J tube is at the intestine, the small intestine. Okay, right. Now, as far as choosing a feeding, there are so many different types of feeding to choose from. And I remember way back when I was a new dietitian, we had a blenderized feeding room in the hospital where we were, because there weren't a lot to choose from. Now, although there are some people that might want to blenderize their own, it's just going to take time, and it's a matter of making sure there's a balance. Okay. Now, depending on where a feeding tube is placed, depending on the GI specialist or the dietitian that you're working with, there's some specific choices that are frequently used. But the typical types, the standard type, means that the carbohydrates, protein, and fat are all in what they call intact form. So those are used for people that have a regular functional digestive tract, and it's fortified with vitamins, minerals. Many have fiber added to them. Sometimes they have prebiotics added to them, so it's good for gut health. The protein source typically tends to be cow's milk, casein, and whey. Sometimes there's soy milk, soy protein that's used, and now there's more and more of the plant-based type of tube feedings that are exclusively pea protein. The milk-based ones are processed to be lactose-free. So if someone has a lactose intolerance, it does not mean that he or she will not tolerate a milk-based, a casein or whey-based feeding. Now, most of the characteristics of the feedings, there's different what they call caloric density, and it's also based on the patient. So some of them are what we call 1 calorie per milliliter, or 1.2, 1.5, or 2 calories per milliliter. So this is good. Someone is having a difficult time getting a volume in a feeding. Now, most of the feedings will contain a certain percentage of water, 70 to 85%, depending on, again, that concentration of calories. So because of that, and because we know hydration is so important, then additional free water needs to be used. Now, frequently, there's some water added to the feeding to increase the volume, if someone could tolerate it. A lot of times, someone will have the tube flushed, like about 1 to 2 ounces, or 30 to 60 milliliters before the feeding is given, and then the same amount after the feeding is given. Now, some people will choose to take some additional water in between feedings, depending on, again, the tolerance. So in answer to the person who had posed, I think it was Dina, who had posed a question about how many fluids, it is based on the person and based on the tolerance. Now, there's a lot of different standard formulas out there, and these aren't even all of them, but some of these might be familiar to you. Jevity, Leplete, Osmolite, Nutrin, then there's 2-Cal. Those are all milk-based. Isosource is plant-based and animal protein choices. There's the plant-based ones, they have complete, And actually Complete has one that's milk-based as well. Liquid Hope and Cake Farms. These are all plant-based because there's people that desire having more plant-based types of feedings. There are feedings called real food blends now that are plant-based and animal protein sources because people want to feel that they're getting more natural sources of food. Okay. Now, what happens in the case of someone having an impairment in digestion? Okay. We do make a lot of other considerations. One type of feeding would be what they call a peptide-based formula. Okay. It's as nutritionally complete as the standard type, but the protein in it and some of the other components will be broken down partially, so it could be easier to tolerate. Now, a lot of times, like I mentioned, these are frequently recommended, and I recommend them a lot to people that do have GI issues affecting digestion, nutrient absorption. Someone has a change, maybe they're having some chronic diarrhea. People that have comorbidities like inflammatory bowel disease, some malabsorption, reflux issues, bloating, which we frequently see. Some people might show more large, what we call residual gastric volume after the feeding. Now, there are even further broken down formulas. One, they're called semi-elemental or elemental feeds, and these are completely broken down proteins into their simplest form to permit very easy digestion with minimal effort, okay? And frequently, these feeding tubes are, especially if they are going into the jejunum, they need to be broken down for best absorption. Okay, as mentioned before, there's many different types of administering tube feedings. The bolus is, again, as Theresa showed you, through a syringe over a short period of time, a few times a day. It's trying to mimic meal and snack times, okay? So people could feel like, they're joining the family and having, that time. And again, the volume varies based on the person's tolerance. It could range anywhere from 180 to 360. I've even seen up to 480 milliliters a person can tolerate. Sometimes we'll have people that might be doing 240 or 360 milliliters of feeding, and then the additional volume will be by water, okay? Like was mentioned before, there's the continuous feedings for those people that need to, have a harder time tolerating bolus feeds. And then the gravity feeds are hung on a pole. We have had some people that have done a combination of both. I've had, people that said, I can't take a huge volume. I can only take a certain amount of bolus, even if we're trying to space it out and doing maybe 4 small feedings or 5 small feedings, but people, they don't feel comfortable with that. So sometimes we'll have people that will do a few boluses during the day and sometimes be on a continuous feeding in the evening. Okay. So that can also work as well. Okay. Complications. Well, again, aspiration, if there's some inhalation in the lungs, clogged tube. So again, that's if the formula is too thick or there's improper flushing or cleaning the tube. That's why that's so important. Infection or leakage. So you have to let a healthcare provider, the nurses at the clinic that you go to, that this is going on. A lot of times they want to see pictures. And again, sometimes there's formula intolerance. So what might prevent, especially aspiration, if someone is sitting upright during the time that the feeding is administered, and flushing the tube, like I said before, and after the feeding will certainly help, and certainly speaking to the healthcare team. So very, very important point, and I think it was emphasized also by Theresa, having a feeding tube place is not a sign of weakness, failure, or loss of independence. Many people feel anxious or depressed or stigmatized by the idea of needing a tube. However, it can make a difference between how someone's outcome is and how they feel and how they can endure treatment, enjoying quality of life, being able to go places. Again, if swallowing remains possible, people could still eat with having a tube because we want people to get the enjoyment of eating. Think of it as proactive. Think of it as stabilizing weight, keeping strength, optimizing treatment, improving quality of life. Okay. Anytime we have people that are on the fence and thinking about, I'm not sure what to do, always feel that this could be discussed with your neurologist, with myself. When I'm at clinic, I discuss it with people. The doctors discuss it, the nurses discuss it, the speech therapists discuss it before a decision is made, because we want you to feel that you are in agreement. We don't want you to be resistant for it. Okay.
Susan, we need to give time for questions. So
yes.
So finish your. You have more slides? Go ahead.
No, that's it. No more slides.
Oh, okay.
I'm done with slides.
Okay. All right. So you can stop sharing.
Oh, okay. I'm sorry. Thank you.
There we go.
Thank you.
All right.
So, I guess we're on the questions, correct?
Yes.
Okay, first question. How much water should a patient have in addition to formula like Liquid Hope?
Go ahead, Susan.
Well, the Liquid Hope is about 70% fluid in the volume. So the volume of Liquid Hope, that's about a 300 milliliter container, or pack, I should say. So it depends on the person. Like I said, if something's 300 milliliters, 300, I'm doing the math here. Okay, so 70%.
That's about 200, probably about 200
210.
cc's of water.
Okay, 210.
Yeah.
Now, if someone needs, most people will need, if you think about half your weight, so if we have someone that is, say, 180 pounds, that person needs 90 ounces of fluid. Okay, an ounce of fluid is 30 milliliters. All right, so 210, that's 7 ounces per Liquid Hope. Okay, so if someone's getting 3 or 4 Liquid Hope a day, okay, so that's going to be 21 to 28 ounces of water just from Liquid Hope. Okay, so if we do the math,
so they need 60 more
that's another
cc's of water,
62 ounces that person is going to need, right? So yep. Which means that that person should have, if tolerated, maybe another 8 ounces per feeding. That's another 24, or 10 ounces per feeding. That's another 30. And then in between, spacing out a bit more, whether it's another 8 ounces, 3 times a day. Does that make sense? The person asking.
So when you do the feedings, we always introduce the feeding by flushing with an ounce or 2 of water. So if you have to lean a little bit more on the higher fluid side. So first you flush with 2 ounces of water, then you give the formula, which is going to have 6 or 7 ounces of water, and then you flush again afterwards with 2 more ounces of water. So each time you use a container, you're getting 10 or 12 ounces of water. And then when you do medication, you're going to mix the medication with 2 ounces or 3 ounces of water, and you're going to flush before and after each time with 2 or 3 ounces of water. So each time you use the tube, you're going to definitely put 5 ounces of water in every time. And then if you notice during the day that you haven't gotten a lot of water, put your 2-liter bottle of water next to you. You want the fluid to go in at room temperature, so always have it nearby. And if you haven't gotten to the bottle, finishing that bottle, then you're going to put some more down the tube. Next question.
Okay, next, thank you. What is your opinion on manufactured blenderized food that is prescribed or high peptide formula? I noticed that many formulas have a lot of sugar that I cannot tolerate.
Okay, so that's why a lot of people will like to have the plant-based or the blenderized ones like the Real Food or the Liquid Hope, because they don't have, all the sugar in there. They have real food in there. So that's why a lot of people prefer that if they could tolerate it. We've had people that have switched to Liquid Hope and have tolerated it very well. Their bowel function is more regulated. Okay. So I don't know what kind of feeding that you're on now, but a lot of them, you're right. A lot of them do have some refined carbohydrates in them, because it's part of another means of getting another source of carbohydrates, another means of getting calories. So that's put in. But I guess if you want to try some of those blenderized ones, to see if you could tolerate that better, it might be worth it. I don't know if I
Okay,
answered
And
your
they
thank
do
you,
question.
have
Sue.
diet, they do have formulas that are for diabetics, formulas that are for people with cardiac illness and kidney disease. So those formulas
Yeah,
are all based on the patient's medical history. So, they would
right.
definitely
They have
plenty of things
booster
that
and
you can try.
Okay,
right,
next
right. They
question. I'm sorry, we have to
Next
move on.
question.
That's
Yeah.
okay. That's
How do I find a dietitian if my clinic doesn't have one?
Well, I would say
if
that you could go to your PCP. They may be
right.
able to refer you to a dietitian. Most clinics do have a dietitian. I can probably think 1 or 2 that don't, but we can maybe get a consultation with one of the dietitians at another
If
clinic.
if the clinic is attached to a medical center, chances are they probably have an outpatient area also that
Mhm.
the person can have an
We can
appointment
refer.
with the dietitian there.
Yeah.
Okay, thank you. Next
Okay.
question. Why so many grams of grains versus vegetables? Is it the fiber or is it for quicker energy and higher calories?
Grains
Well, it's
versus
probably a
fiber.
combination of both. Yeah, for the fiber, and it's also, yeah, for calories. But I mean, I was just using, you're talking about that example I showed as far as food. Um,
Mhm.
yeah, I mean, if you think about vegetables, there's a lot of volume with vegetables, and they're calorically dilute. So that's why, a lot of times we want to have a balance of a combination of different foods. That was just an example. Certainly people eat different ways. It was just an example to present, to say there's a lot of food involved if someone wants to consistently get enough calories. Yeah.
Okay,
But
Okay,
people,
so
if a
we're
pa
running out of time.
we're running out of time. If a
Yeah, go
patient
ahead. One more question.
complains, if a patient complains of diarrhea even after switching to a non-dairy formula, is there any reason not to take an over-the-counter remedy like Imodium?
No, that's fine. You should discuss it with your doctor or your nurse practitioner, and they'll go over the proper medication for you. Sometimes it's just you getting more fluid than you had been before, and your body is adjusting to it, and you will wear
Uh,
through. I think we're out of time though, so we're going to have to cut this off. If there are any other questions, we'll do our best to answer them via email.
yes, there are other questions. I don't know how to save
Okay.
it though.
Okay.
How to treat a patient with a feeding tube that has significant reflux. What can happen? Blocking of the tube with self-blended food. And what do I do if
Oh.
the flow in the tube stops?
So, okay, these are all questions that I don't know how to answer them later. Clogged tube, you have to go to the emergency room. That's a big problem with the home blending is they will clog the tube. and you need to tell your doctor immediately if it slows down or clogs. All right, thank you very much, everybody, for coming on today.
But if they have
I really
questions, you can
enjoyed.
always. And I'm
Yeah,
sorry
you
about
can
the
email it.
technological blur.
That's okay. Okay, we have to log off. Another meeting is happening. Bob?
Right. Please join
Okay.
us for the next session starting at 10:30. We have 2 breakout sessions that you may have pre-registered for. Thank you for joining us, and questions can also be redirected to your clinic team for additional suggestions and specifics for yourself. But thank you for joining us today.